of time, আমার মনে হয় যে say next speaker you can call, and after that speech there are some questions.
I would like to request Assistant Professor Dr. Mohammad Mokhlesur Rahman Sazal, Department of Vascular Surgery from National Institute of Cardiovascular Disease, to come to dais. His topic is how to deploy peripheral stent. Assistant Professor Dr. Mohammad Mokhlesur Rahman Sazal. Thank you.
Assalamu alaikum, my respected teachers and my colleague. Welcome to today's endovascular session, step by step. My topics is how to deploy the stent. This type of stent, all are the balloon expandable stent, self-expanding stent, and covered stent, all discussed by my previous Dr. Jebhai. This is the self-expanding stent. We are mostly using the Medtronic one. Also, we use Boston Scientific stent. Recently, we are using Abbott's stent. And this is the balloon expandable stent. What we are using Medtronic and the advanced Meditech's on Neptune balloon expandable stent. It's the covered stent. The covered stent is balloon expandable, self-expanding, and also stent graft. Now come to my topics to how to deploy stent. At first, stent selection points to be considered location of the lesion, like location at the movement site, the knee at the knee or hip joint. The length of the lesion is short. We can use balloon expandable stent. And its lesion is long, we can use self-expanding stent. And the type of lesions, like if it is calcified lesion, fibrotic lesion, or thrombotic one. The stent selection is the flexible stent. The Medtronic said they have flexible stent EV3, and also the Abbott they brought recently the flexible one, the C1, and the rest two are not flexible. Strategy of stent deployment. If we do P-dilate or not. Nowadays we are not doing P-dilate, but sometimes we do if there is difficult to cause the lesion. That in that case we do P-dilatation. Otherwise, P-dilatation we are not doing nowadays. Post-dilatation is necessary for self-expanding stent. And balloon selection, we usually choose balloon appropriate size of the stent, and the heparinization is adequate heparinization needed in endovascular procedure. Approach to the lesion and lesion preparation is a proper wire selection. Usually we use exchange wire for endovascular stent deployment. Use of long sheath for long remote lesion like SFL lesion or subclavian lesion. We usually use over-the-wire delivery system. Lesion crossing avoiding injury, and distal arterial bed. Distal arterial bed, we have to look for distal arterial bed is okay or not. If this distal arterial bed is not well visualized, if we placed stent, then there is chance of early stenosis or occlusion. Stent preparation before deployment is unpacking. We should maintain sterility, heparin flush irrigation from the port. Deployment tips and tricks. Ensure proper positioning of the stent. Ensure proper positioning of the stent so that we cover the stent, we cover the lesion properly. confirm with P-deployment angiography, check it with dye is properly positioned or not, unlock the hub, deploy under continuous fluoroscopic guidance, start deployment a bit higher than proximal or distal target point. This means just try to deploy the stent just distal to the lesion and reposition by gentle pulling if needed. It can be possible to reposition and recapture if we deploy a small part. In case of Jaguar stent, they said that more than 50% can recapture. So if it is just pushed it forward, then we can pull it back and do a proper positioning. Keep an eye on the position of the sheath and wire. Mostly look for the distal wire that is not pushing the small vessels, distal vessels, so that the perforation can happen. Never lose, and the last one is never lose control of the wire. Post-deployment trips. Post-dilate whenever necessary. Usually we do post-dilatation with, in case of self-expanding stent. Use appropriate size balloon. Use new balloon. Never. Sometimes we use ox balloon after sterilization. Do not overinflate. If we do overinflation, there is chance of rupture, perforation. Check for distal flow after the deployment. Check for distal flow is okay. If there is any, check for any embolization, the new thrombus formation. Check distal pulse after procedure. Ensure adequate heparinization. Do ACT if necessary. Post-procedural tips. In case of remote lesion, if we are using the long sheath, change it to the short sheath. Check puncture site and patient condition. If the procedure is too long, then there may be chance patient may be feel discomfort. There may be chance of failure if we use too much fluid to the patient. There is the EI stenting. This patient has left iliac artery stenosis. We cross it from the contralateral right CFA. After positioning of the stent, we are deploying the stent from the acetabular margin and repositioning it by pulling. You see the top that we are pulling the stent to reposition it. After deployment is balloon dilatation. This patient has bilateral iliac artery stenosis. On the left side, we did we used self-expanding stent, and the right side we used balloon expandable stent. Okay, thank you.
Thanks a lot, Professor Dr. Mokhlesur Rahman Sazal.